Good evening, everyone. My name is Michelle Galazewski. I am a Partner Relations Director with Eversight, and on behalf of everyone at Eversight, I would like to thank you for joining tonight's program, The Impact of COVID-19 on Ocular Disease and Donor Tissue. In an effort to eliminate all background noise, all participants will be muted throughout the duration of the webinar. If you would like to ask a question, you may do so by typing your question into the Q&A panel at the bottom of your screen, and we will address all questions at the end of the presentation. At this time, I would like to introduce our speaker for this evening. Dr. Shahzad Mian is a professor of ophthalmology and visual sciences at the University of Michigan Medical School, Kellogg Eye Center, Michigan Medicine. He also serves the department as associate chair for education. He earned his medical degree in 1996 from the Emory University School of Medicine, and then completed a residency at the Wills Eye Hospital of Thomas Jefferson University in Philadelphia. From 2000 to 2002, Dr. Mian was a fellow in cornea and refractive surgery at Mass Eye and Ear, Harvard Medical School. He joined the Michigan Medicine faculty in 2002 as a clinical lecturer in ophthalmology and visual sciences, and was promoted to associate professor in 2010. Also joining us this evening, Michael Titus with Eversight. He joined in 2017. He is the former Chief Clinical Officer of Saving Sight, an eye bank in Kansas City, Missouri, where he successfully crafted the strategic direction of its clinical program, oversaw lab renovations, and improved tissue quality and surgeon satisfaction. Prior to his time at Saving Sight, Michael excelled in various roles with Eversight from 2008 to 2013, including managing the laboratory in Michigan and playing an instrumental role in developing the Eversight DMEC program. He is a certified eye bank technician and currently serves on the Eye Bank Association of America Research Committee, Accreditation Board, and Advisory Board. Dr. Mian, you can begin.
Great, thank you so much. It's a great pleasure to be here with everyone. Good afternoon, everyone. My topic today is to cover ocular manifestations of COVID-19. As all of you are experiencing, all of our lives have really changed dramatically over the last 3 months, both professionally and personally. And in ophthalmology, we're always curious about what's happening with respect to COVID-19 and eye disease. It is not a common manifestation, but certainly can present, and it's important for us to be aware of findings that occur. What's fascinating is that the knowledge base for COVID-19 and its impact on not just the eyes, but with everything that it does, is rapidly changing. And there's really almost new information on a daily basis. So how do we keep up with this information? Well, it's nice to have webinars to share knowledge and information. For us working at universities like University of Michigan, we get to work with amazing medical students. And I would like to give a shout out to our great medical student, Eileen Fang, who really helped put together this presentation and actually gave this presentation, a similar presentation at our grand rounds not too long ago. She's applying to ophthalmology. For any of you who are in residency program, she's amazing. So we'll start with ocular manifestations and what we really need to know. So how can COVID-19 affect the eyes? Well, there are 3 different ways that we can view the impact of COVID-19. One is related to actual treatment. So patients, at least until recently, it was really quite popular to consider hydroxychloroquine treatment for patients who are hospitalized and also were managed on an outpatient basis. There are recent studies, including one today that came out looking at prospective outcomes of 800 patients, showing that there was no significant difference in complication rates, including ICU admissions and hospitalization length with use of hydroxychloroquine. Anyway, the point here is that hydroxychloroquine has been used, and as we all know in ophthalmology, can have a toxic effect with long-term use, which would not apply here with short-term use. Patients can also develop Stevens-Johnson syndrome or toxic epidermal necrolysis as a drug reaction to some of the medications, including antibiotics, such as azithromycin, which has been used not uncommonly in management of COVID-19. Patients can also develop syndromes, as we're learning in their recovery after COVID-19, including toxic shock syndrome, which is a condition that can develop a septic condition that can develop due to secondary bacterial infections after a viral infection, and as well as other multi-system inflammatory conditions that primarily have been reported now in younger patients, children, similar to Kawasaki's disease. In addition, of course, what we'll focus on mostly during this talk is the impact of COVID-19 directly on the eye as a viral infection. There are case reports, a number of growing case reports and series which reflect these findings. So eye symptoms that are directly related to COVID-19 because it can be transmitted through contact of mucous membranes with infectious respiratory droplets lead to several questions that we can ask ourselves. What are the ocular symptoms directly related to COVID-19? Can virus be detected in tears? Is there a relationship between ocular symptoms and detection of virus in tears? Is ocular transmission possible? Is there an association between ocular symptoms and the clinical course of the disease? So we'll start with what are the ocular symptoms that are related to COVID-19. A number of published studies, primarily retrospective, have implicated conjunctivitis as one of the findings in COVID-19 clinical spectrum. Most of these studies indicate a relatively low rate. There is one study which is relatively small that shows a high rate up to 30%, but most of them are much smaller in number of cases. But nevertheless, conjunctivitis has been described and is the most common ocular symptom associated with COVID-19. Interestingly, there is a more recent report looking at retinal findings. This was a case series looking at 12 adults examined 11 to 33 days after COVID-19 onset. These patients were PCR positive for COVID-19 or antibody positive, which showed who had normal visual acuity, but were found to have hyperreflective lesions at the level of the ganglion cell and interplexiform layers on OCT. And 4 patients even had cotton wool spots and microhemorrhages along the retinal arcade. It is not really clear what the mechanism of this is, but this is an association that has now been reported. So retinal findings are certainly a possibility as well. Can the virus be detected in tears? So we have a few studies to look at in terms of the data, a few prospective and retrospective, and a larger cross-sectional study which show low rates, but yes, virus that is present in the tears as well. So it can be detected when using PCR testing, although again, there's no clear relationship when we look at symptoms and association of having a positive PCR in the tear film, meaning that you can have a positive PCR and tear film testing with no symptoms, and you can have a conjunctivitis presence with a negative PCR. I think what's really interesting, what we're learning about in terms of ocular transmission and the possibilities is the mechanism of how it could be transmitted. The SARS-CoV-2 virus, which is the virus responsible for COVID-19, uses ACE2 receptors for cellular entry. It also uses another protease for activity for how it infects cells in its transmission. Now, these when we look at the genetic profile of cells, including in the eye, there is ACE receptor expression that's present in the limbus, corneal epithelium, and conjunctiva, although it seems like this expression is on the low side. There's also co-expression of this protease in the superficial conjunctiva, and ACE2 has also been detected in human aqueous humor and the retina as well. So this would lend itself for us to think that there is the possibility that the SARS-CoV-2 virus can replicate and be present in a human tissue, in human ocular tissue. There's also replication ex vivo in cultures of human conjunctiva. There was an interesting study looking at rhesus monkeys by infecting them with SARS-CoV-2 virus in the conjunctiva to look at if that could lead to transmission. They noted in the study that the viral load was detected in conjunctival swabs on day 1 post-inoculation and then became undetectable. And these monkeys did subsequently develop interstitial pneumonia. Post-mortem analysis showed that the viral load detection was most heavily present in the nasolacrimal system, oral cavity, tonsils, pharynx, and as well as in the lungs. The transmission was thought to occur through the nasolacrimal duct through drainage into the nasal passageway, where there tends to be a heavy load. And this does correlate clinically as well. So ocular symptoms can be an initial manifestation of COVID-19 as well. Ocular symptoms can potentially be associated with disease severity also. So we have seen this with case reports. There are several case reports that were published relatively early, including this one, which showed that patients can have a patient who presented with conjunctival injection, discharge, fever, who was later then tested on to having being COVID positive, then improved, and then the conjunctivitis improved as well. So the natural history was documented where the conjunctivitis was actually diagnosed prior to COVID-19 testing and systemic disease. There's also a report looking at patients with ocular symptoms. They're more likely to have more disease severity as assessed by inflammatory markers, including white blood cells and neutrophil counts, with procalcitonin, CRP, lactate dehydrogenase, which are all markers of systemic inflammation, again, having higher numbers when patients had ocular symptoms as compared to those who did not. We are also looking at our own patients at Michigan Medicine to see how many have had ocular involvement. We have had, looking in a look back period between March 10th, where the first case was reported in Michigan, to April 13th, we have about 440 patients who were admitted to the hospital. We're looking to see retrospectively their severity of systemic disease, as well as looking at their ocular findings. So far, we're seeing about a 2% rate of ocular symptoms. So this is a all-encompassing of having conjunctival injection, as well as some symptoms, which presented 6 to 20 days after initial presentation. We are also going to follow up on these patients to see if we can identify how fast they fully recovered. So in conclusion, COVID-19 may indirectly cause ocular symptoms through medication side effects and as a post-infectious complication. Ocular symptoms directly related to COVID-19, including conjunctival injection, discharge, foreign body sensation, dry eyes, and retinal pathology at this point in the one case series we discussed. The ocular symptoms can present early in the illness, including being the initial presenting sign. Ocular symptoms may potentially be associated with more severe disease. The reported rates of ocular symptoms directly related to COVID-19 have been quite variable, although overall seem to be low, and in our experience so far, suggests also a low rate of about 2%. There is no clear association between viral detection and tears and ocular symptoms in the series that have reported it thus far. Again, patients with PCR positive tear film may not have any ocular symptoms, and patients with ocular symptoms may have a negative PCR, which may be a function that the tear film may be infected early in the course, leading to nasopharyngeal spread, and then detection of in the tear film being reduced as the eye heals. Transmission of COVID-19 is possible through ocular secretions, and we also, again, have noted that the mechanism exists for the virus to infect ocular tissue, including the conjunctiva and the cornea. Ophthalmologists, of course, are potentially at higher risk, and therefore extra precautions, including proper PPE and breath shields, are essential to reduce the risk for patients and for providers both. I will end there, and again, I just want to thank Eileen Feng, our medical student, who's done an amazing job in helping me keep up to date with the references that are ever expanding on a daily basis. Thank you.
I wanted to spend some time just to review with everybody some of the things that we have done throughout the course of these challenging times to help ensure that the donor tissue that you're receiving is safe, and to provide a little bit of a preview of what we are expecting over the next, in the near future as it relates to all of this. We begin all of our meetings in our offices with our mission: we restore sight and prevent blindness through the healing power of donation, transplantation, and research. We like to share that wherever we can because we're very proud of the work that we do. To really help understand how tissue is kept safe, not just in these times, but overall, I wanted to spend some time really talking about the architecture of safety that exists, not only within our own organization, but through the bodies that we work with across the US and with the federal government to really help ensure donor safety. So I want to spend just a little bit of time giving some of that framework, sharing some of that framework that really helps to build our foundation as an eye bank. I think that the first real cornerstone of this was the formation of the Eye Bank Association of America. It was a collaboration among eye banks and cornea surgeons to standardize procedures. This was done in 1961, and I think the important point of this is that this was an early awareness among eye banks that they really needed to follow best practices and that we needed to work collaboratively with surgeons to really help establish what those are. It was the first national transplant organization to establish medical standards. Those were formalized and codified in 1980. Those are now currently maintained by the Medical Advisory Board, and they're also AAO approved. So there's very close collaboration between eye banks and surgeons. Interesting part, or a key part of who we are, is that Eversight staff and our medical directors are very active members at all levels of the Eye Bank Association. We, of course, have federal regulations. The Food and Drug Administration oversees all of the human cells, tissues, and cellular and tissue-based products, shortened to HCTPs, and provide guidance on all of those. The comprehensive regulatory program was really established in 2001. Prior to that, there was kind of a mix of different regulations that helped to oversee all of these different products that share similarities. And the real focus of this regulation is to prevent the introduction, transmission, and spread of communicable disease. And primarily the focus there is through donor screening and through disease testing. Later in 2005, the current good tissue practices were established. Those provide a little bit more of a framework for implementing some of the regulations that are outlined in HCTPs. And the focus there is, again, on the preventing infectious disease contamination and its cross-contamination. A key outcome of the GTPs was establishing and maintaining a very comprehensive quality system. And eye banks have done a very good job of taking that on across the board as well. And then finally, internally, our Eversight has its own medical advisory committee. It's composed of our medical directors. The policies and procedures that we use are approved by the clinical and quality teams, and they really outline all of our standards and protocols for eye bank functions. These are also approved by our medical directors with any changes, updates, and at least annually as well. So all of these things really come together to provide a very strong framework for how we handle tissue and how we ensure that it is safe to provide for transplantation. And the two main areas of focus there are through the donor history and through tissue handling procedures. Let's talk just a little bit about those. The donor history really ensures that the medical and social history of the donor meets all standards, and those standards are outlined in all of those regulatory pieces that I talked about just a moment ago. We do a number of different steps for each of these cases. There's the initial screening with the hospital. Generally, that's with the nurse that was just caring for the donor at the time of the donor's passing. In addition to that hospital screening, we also speak with the family members or with a person that is very knowledgeable about the donor's medical and social history, and we perform the donor risk assessment interview. In addition to that, we perform full medical record reviews, as well as consults with our medical directors. If medical examiners are involved in any of the cases, we ensure to get consultations with them, or infectious disease consults where necessary. And there may be others depending on the case, but we do a lot of work to really ensure that we have full donor history to make a very good decision on whether this donor's past medical and social history does not preclude that tissue from being utilized for transplant. And then tissue handling is another large component of this. Our procedures really ensure that we prevent contamination of the tissue in any of our handling of the tissue. So strict adherence to antisepsis protocols in the recovery and the processing. The recovery, there's a couple pieces that are performed. The donor body exam is a key component of all of the recoveries. Really do a full examination of the donor's body, looking for primarily for any high-risk behavior, such as IV drug use, that would preclude that donor from providing safe tissue for transplantation. In addition to that, we also perform preparation of the ocular area similar to a surgical preparation. I want to talk just a little bit more about that. And then, of course, a laboratory evaluation of the tissue, cell imaging, and slit lamp exam. Our ocular preparation is a little bit unique from other eye banks and has changed recently. But we do perform an extensive cleaning around the periorbital area. We use povidone iodine at 5% concentration for 5 minutes. We've used povidone iodine for a long, long time. But in November 2019, as a result of some different studies that came out that talked about performing a second povidone iodine soak, we modified our own recovery procedures to take advantage of those benefits as well. And we implemented a second povidone iodine soak. We perform ours after the conjunctival removal. There's still a lot of work to be done to kind of really say when the best time to do the second soak is. But our theory behind this is really that the initial soak done before any incisions or any conjunctival removal is performed is a good first cleaning, and then removing the conjunctiva and allowing the povidone iodine to actually touch the tissue that is going to be stored in the tissue solution to have that exposure to povidone iodine. As part of our evaluation of really looking if this was a good direction for us to go, one of the concerns that was raised was around epithelial toxicity. We performed vital dye staining on mated eyes. Right now, 12 pairs of mated eyes, and we'll be presenting those full results at the Eye Bank Association Scientific Symposium for the virtual meeting. But our data really shows that there's no difference in toxicity, at least experienced and recorded within 24 hours after the recovery, between a single povidone iodine exposure and a second povidone and a double povidone iodine exposure. And those are some of the images that we took in our laboratory in Cleveland in our research center. We're very proud of this early data that's come out since our implementation of this second povidone iodine soak. Previous to that, our post-operative rim culture reports that we received back to the eye bank hovered right around 1.2% of all transplants that occurred. We received a report of a positive rim culture. Starting in November, that went down to just under 0.5%, and January is at 0%. In addition to that, we've received no reports of post-operative infections in the recipients since that November 2019, since we implemented that. So I want to talk a little bit more specifically about what we were doing for SARS and how some of our protocols have changed in response to this. It has been a very ever rapidly changing scenario for us. In January 21 or January 21st, the first case was announced in the US. Just shortly after that, there were screening changes that included travel to China or any suspected exposure within the previous 28 days was added to our screening protocols. In February, as things started to became more apparent that the virus was spreading to other countries, February 20th, the first death was recorded in South Korea. In the 25th, our travel restrictions were expanded to include other countries that had reported the virus in their populations. And then at the end of February was the first death in the US. And that really changed a lot of the way that the Eye Bank Association really looked at this, and they implemented much stronger criteria around screening for the symptoms of COVID-19. And that was the really first run of it. And those have changed as well as more information has come to light about the virus, its transmission, and all of the different signs and symptoms that are found to be common with it. So in March 26th, the deferral time was actually increased to 2 months, and travel was expanded to include all CDC recognized areas. On April 17th, the current screening protocols that are in place right now were implemented, and I'll go over those in a little bit more detail here. The emphasis really is on the donor history, and it does rely heavily on consults with medical directors. The first piece of this is that if there's any COVID signs within the past 28 days, such as ARDS, pneumonia, pulmonary CT, especially with the ground glass opacities, that is a deferral. Development of COVID-19 symptoms within the past 28 days, one of the following: cough or shortness of breath or difficulty breathing. You can imagine that most of our donors fall into that category. Or two of the following: fever, chills, repeated shaking, new lost taste of smell. Any of those show up, then we're performing much more investigation to really ensure that there's safety for that donor. If there's close contact with an individual with COVID-19 as defined by the CDC, and primarily that's without PPE, or if there's a positive or indeterminate PCR test within the last 28 days. And all of these things kind of really work together. The Eye Bank Association has created a guide. I won't go through this in detail, but just wanted to give you an idea of kind of some of the different ways that all of these things impact each other. If there's a negative PCR test or the test isn't performed, a negative test doesn't automatically clear a donor for transplantation. There still is heavy emphasis on the signs, the symptoms, and then also heavy emphasis on consulting with a medical director. So in any of these scenarios, we really end up in very few scenarios with cases that are eligible, free and clear. Most of them require a medical director to review the details of that specific case in order to clear the tissue and provide it for transplantation. A little bit more beyond just the screening, though, goes back a little bit to the ocular preparation. There are three key studies that I pulled out that really talk about the virucidal activity of povidone iodine with coronaviruses. The first major one was in 2006 that reported that povidone iodine was effective with 1% concentration for up to 2 minutes. In 2015, as MERS and SARS also, MERS became more popular, the inactivation they evaluated with between 1 and 7.5% with concentrations with up to 30 seconds exposure times. And then most recently in 2020, actually, this last one is a literature review that evaluated many different studies and showed that the inactivation of coronaviruses in general was effective between 0.23 to 7.5 concentrations for up to 1 minute. There were no data just yet that was available at the time that I did this presentation showing that SARS-CoV-2 does actually is actually eliminated through povidone iodine, but there is strong evidence to suggest that it is likely the case is it is also coronavirus. In addition to the ocular preparation that we're performing, starting this week, we've begun testing all of the donors via nasopharyngeal PCR testing. We are also accepting a hospital test that has been performed within 3 days of cardiac death. And this doesn't necessarily just clear a donor. We do really pay attention to all of the additional signs and symptoms, but it does provide an additional data point for us in determining donor eligibility. And I think that it will be a valuable piece of information for you as you are evaluating tissues for your surgeries. Finally, Eversight, along with Dr. Mian and Dr. Majmadar in Chicago, were awarded the EBA grant for analyzing the effect of COVID-19. We're really looking at 2 major aims: determine the regional infiltration of SARS-CoV-2 in ocular tissues. So we're going to be looking for the virus in tissues beyond just the conjunctiva. And in addition to that, as a side piece to that, we will be looking and testing in mated eyes the effectiveness of povidone iodine for the inactivation of SARS-CoV-2 in the ocular tissue. In addition to that is really an overview and understanding the full impact of COVID-19 on the cornea donor pool. So we want to really determine if one, what is the full impact? And then if routine testing is really a beneficial route for us to go as an eye bank and as a community. Going forward, really, continued assessment of everything that becomes available will drive our policies and our practices. But the key piece to all of it, and really what we are interested in doing and have our key and core to our mission, is providing safe donor tissue for transplantation. Thank you, everybody, for listening and joining us this evening. Here's my contact information. Please feel free to reach out to me if you have any questions, anything that I can help you with.
And Dr. Mian, if you'd like to join us back on screen, you can. We have a question for you. Do you think retinal manifestations are due to secondary effect of the altered blood oxygen levels resulting from the patient being on a ventilator or compromised respiratory function rather than a direct effect of the virus?
It's a great question. I don't think I have the answer, and I'm not sure anybody has the real answer. None of the patients in the case series were admitted, so they were not on ventilators. So I don't think that that is the likely explanation in this cohort of patients. But perhaps it's a vascular involvement that has been noted in other syndromes, inflammatory conditions, as in children, what has been noted, the strokes that have occurred. So it's not clear, but certainly it is possible that there is a vascular component to COVID-19, and that is the source of what is affecting the eyes. Whether it's ischemia or not clear.
Okay. Next question from Dr. Alan Sugar. Should we treat patients presenting with viral conjunctivitis differently than we did in the past?
Well, it's a great question. Certainly, because COVID-19 pandemic is still very strong in our communities, and there is a risk that somebody who has conjunctivitis may have COVID-19. The most important thing that we can do is to screen our patients appropriately before they come to our office, and certainly in the office to screen as similar to the screening questions that Michael was mentioning, to ask them about their exposure risk to COVID-19 and their symptoms other than their conjunctivitis that may increase their chances of having COVID-19. If that is the case, then they should be tested appropriately for COVID-19, and we should use appropriate PPE to reduce the risk of any additional exposure to other patients as well as to the providers. So would I treat viral conjunctivitis any differently than I did before? Not necessarily at this point, although there are case reports using topical antivirals to manage COVID-19 associated conjunctivitis, as there are for adenoviral associated conjunctivitis.
One more. When will the results of the EBAA grant study be ready?
Well, it's an excellent question. We just got awarded the grant about a week ago, so we're working on our plans to execute and try to get the results out, I hope, as early as within a month, especially for some of the clinical results, but I suspect the laboratory testing may take a little bit longer.
Okay, at this time, there are no further questions. So I would like to thank everyone again for joining us today. The webinar has been recorded and will be available on our website to view on demand. You'll be receiving a follow-up email shortly after the webinar concludes, and it would be greatly appreciated if you would provide us with your feedback on today's session. A special thank you to Dr. Mian and Michael Titus for serving as today's speakers and for providing us with your invaluable expertise on this subject. Have a wonderful evening, everyone. Thank you, Michael and Dr. Mian.
Thank you, everybody.
Have
Bye-bye.
a great evening.
Bye.